Hello. Good evening, everyone. Welcome to today's session on cortical spreading depolarization. Today, we have our moderator, Dr. Rajiv Kumar Mishra, who is Associate Professor in the Department of Neuroanesthesia and NIMHANS, Bangalore. And we have presenter, Dr. Gayatri Sakrikar, who is an Associate Consultant in Kokilaben, Mumbai. So today's topic is a very fascinating and deep dive into a critical and often misunderstood neurological phenomenon, which is the cortical spreading depolarization. So often it comes up in many important patients who are critically ill, like stroke, traumatic brain injury, in whom not just understanding this is an academic exercise, often it is important for us to plan effective treatment and to look at the prognostication in this group of patients. So today's webinar will demystify CSD for all of you. And over to you, Dr. Rajiv, for opening remarks and then to take over the session.
Thank you, Dr. Bharat. And thank you, the entire NCSI, for giving us the opportunity to speak on this cortical spreading depolarization. As Bharat has already told, what is cortical spreading depolarization? It is not just a profound neurological event that leads to neurological depolarization across the glial cells as well as the cortex. It also leads to a lot of changes in the cerebral hemodynamics. Especially, it can lead to decreased blood flow and ischemia. So, to understand that pathophysiology in deep, we have Dr. Gayatri, who is from Kokilaben Hospital. She will be speaking on this topic in depth and the clinical implications of this topic, and what are the different pharmacological and non-pharmacological methods to tackle this problem will be dealt in this topic. Over to you, Dr. Gayatri. Please start the presentation. Thank you.
Good evening, everyone, and thank you, Rajiv sir, for your kind introduction and opening remarks. And I will thank NCSI for this opportunity and start with my presentation right away. So today's topic is cortical spreading depolarization, and we'll be covering the definition and background, its pathophysiology, vascular response, how to monitor them, its clinical implication, and the therapeutic targets. So spreading depolarization or the cortical spreading depolarization are waves of electrical silence caused by mass neuronal depolarization of the neurons and the glia, that is the gray matter of the brain, and it is triggered by acute neuronal injury of any pathology or etiology. The incidence of spreading depolarization in traumatic brain injury and intracerebral hematomas is about 50 to 60%. In aneurysmal subarachnoid hemorrhage, it is about 75 to 80%, and in malignant ischemic stroke, it can reach up to 90 to 100%. These spreading depolarization result into a catastrophic consequences, leading to the secondary brain injury, and therefore they are rightly named as brain tsunamis. So the discovery of the spreading depolarization goes back to 1944 when Aristotle A. Lau discovered that there are presence of a series of electrically silent waves spreading across the serially pressed cortical electrode while he was studying seizure activity on the rat's brain. He then observed that this silencing electrical activity was restored after some time in the same order that it disappeared, and he named it as a spreading depression. He initially considered it as an experimental artifact until 1970 when he himself observed a similar changes when the blood flow was stopped into the cortex. And this phenomenon was later on described as spreading depolarization. So, spreading depolarization are slow waves of propagating at the speed of almost 2 to 5 mm per minute. They are self-propagating. They are abrupt in onset, intense but transient. And the changes that follows the spreading depolarization is focal, in nature and lasts for about 15 seconds or more. The propagation of the spreading depolarization requires a gray matter continuity, meaning that presence of any large vessel or surgical margins or a major sulcus will prevent the further spread of depolarization because of discontinuity in the gray matter. Because of the depolarization, the extracellular space becomes negative. And since this wave is very slow, it appears as a large and negative and direct current shift, which can be observed as a negative shift in a direct couple extracellular recordings. To before we move further, it is important that we clarify an important difference between spreading depolarization and spreading depression. Often these two terms are used interchangeably, but they describe two distinct phenomena. Whenever the membrane gets depolarized, it cannot generate any further spontaneous activity or the action potential, and this leads to the abolition of the spontaneous electrical activity, which is spreading depression. So spreading depression is always a consequence of a spreading depolarization, and hence it also has a similar velocity as the spreading depolarization, that is about 2 to 5 per minute. So here you can observe that there is a spontaneous electrical activity in the brain which gets abolished after the spreading depolarization marked by the negative DC shift. So spreading depression happens only after the spreading depolarization. But what happens when the spontaneous electrical activity is already suppressed, as in the ischemic core, where there is a electrical silence? In that case, the spreading depolarization still do occur, but it is not followed by the spreading depression. So spreading depolarization can occur without the spreading depression, but a spreading depression always requires a spreading depolarization to happen first. So the genesis of the spreading depolarization begins with a trigger. It could be hypoperfusion, hypoxia, hypoglycemia, or in vitro it could be a noxious stimulus in the form of mechanical injury or an intense electrical stimulus. So this triggers causes opening of the large conductance cation. So the cation starts moving along their concentration gradient. So the sodium and calcium moves into the intracellular space, whereas the potassium moves out into the extracellular space. This changes the polarity of the membrane and causes membrane depolarization. Now, a depolarized membrane causes further increase in the intracellular calcium that releases glutamate, aspartate, or ascorbate, which eventually recruits more and more cationic channels, and the depolarization gets sustained. The ionic imbalance in the spreading depolarization is so massive that the potassium in the extracellular space drops from 30 millimoles to about 60 millimoles, whereas the calcium increases from 1.2 to calcium decreases from 1.2 to zero point 0.1 to zero point 0.2 millimoles, and sodium decreases from 150 to 50 to 70 millimoles. This difference in the polarity causes influx of water within the neuronal membrane, which leads to the neuronal swelling or the neuronal bleeding. So this imbalance in the ions across the membrane is restored as long as there is a continuous supply of energy in the form of ATPs, so that Na plus K plus potassium pump can work efficiently and restore this ionic imbalance. In the pathological conditions, whenever there is a persistence of persistent hypoperfusion or hypoxia or hypoglycemia, there is an insufficient supply of ATP to sustain the function of these sodium potassium channels, and the ionic restoration cannot happen, and there is a buildup of potassium ions in the extracellular space, and that membrane does not get repolarized and the depolarization persists. So the SD is reversible as long as the supply demand matches. Another system that works in order to maintain the extracellular potassium ions in check is a glymphatic buffer system that consists of the astrocytes and the neuronal gap junction. These gap junctions consist of various channels like delayed rectifier potassium channels, calcium activated potassium channel, or stretch activated potassium channels. These get activated in presence of excessive potassium and causes buffering of the extracellular space that leads to the dampening of the SD. But in case of a pathology like persistent subarachnoid clot, which keeps on releasing potassium into the subarachnoid space, this potassium levels crosses the physiological ceiling of this buffer system, and these delayed rectifier channels become inefficient. And instead of buffering the potassium, this gap junctions help in causing spread of this potassium, and thus helps in the propagation of the spreading depolarization. So this ionic exchange leads to a voltage change of almost minus 30 to minus 50 millivolts. And such intense voltage change puts a huge metabolic burden on the brain. The ATP levels drops down by almost 50% at the beginning of the spreading depolarization itself, which is followed by the glucose, which drops by 30 to 60% about at the peak of repolarization, followed by the glycogens, which also drops by about 50%. Once these levels are dropped below 50%, the anaerobic metabolism starts occurring, and the lactates goes up to 2-folds. The recovery of the ATP is relatively shorter, which happens in about 1 to 2 minutes. But for the glucose, it takes about 5 minutes, and the glucose level actually show a temporary overshoot to compensate for the lost glycogen store, which later on gets recovered in 10 to 90 minutes. The CMRO2 as well as the cerebral metabolic rate for the glucose also goes up to 2 to 3 folds, and the CMRO2 takes about 2 hours even after the depolarization is abolished, so as to replace the lost stores. So such intense metabolic response carries forward with it an inadequate vascular response as well. And there are typical 4 phases of the vascular response following the spreading depolarization. Initially, there is a transient hypoperfusion because of excess of potassium. It lasts for about 5 seconds and it is immediately superimposed with a peak hyperemia, which increases the cerebral blood flow to the pial vessels by almost 100%. And this is achieved by by dilatation of the small caliber pial vessels rather than the larger cerebral arteries. And this peak hyperemia also propagates as the spreading depolarization propagates further, and hence it is called as a spreading hyperemia. It outlasts the spreading depolarization and gets diminished only after the repolarization pursues. This is later on followed by a small peak of late hyperemia, which starts about 3 to 5 minutes after the completion of DC. And this is followed by a prolonged spreading oligemia or vasoconstriction that lasts for almost 2 hours even after the spreading depolarization is complete. This neurovascular response shares similar features with the neurovascular coupling response that we observed under normal physiological function, but the only difference is that the astrocytes here are the primary driver behind this kind of neurovascular coupling. Because of the increase in the intracellular calcium within the astrocyte, it activates the cyclooxygenase pathway that releases PGE2 and other vasodilators, which helps into this vascular response. Apart from the astrocytes, the pyramidal neurons as well as the perivascular neurons also takes part into this coupling response, and this usually is mediated through release of nitric oxide or adenosine or other vasopeptides. The pericytes comes into picture in the beginning of this vascular response, because they undergo constriction, and in response to the oxidative stress, they are responsible for the phase 1 hypoperfusion as well as the phase 4 spreading oligemia. So under normal physiological condition, the spreading depolarization initiates a spreading hyperemia. And as the supply energy demand matches, the membrane gets repolarized again, and the depolarization is usually a short lasting one. But whenever there is a pathology, instead of spreading hyperemia, an inverse hemodynamic response happens. So we get vasoconstriction instead of vasodilation, and the spreading depolarization prolongs because of the supply demand mismatch. And this inverse hemodynamic response is called as a spreading ischemia. Now, the mechanism behind this inverse hemodynamic response in the pathology is not very well known, but some of the reasons could be because of the neuroinflammatory mediators that are involved in the pathology, such as TNF alpha or interleukin 6b or caspase, which causes these vasoconstrictory responses. So in real time, the spreading ischemia appears like an intense pial vasoconstriction, which we can observe in this video. From right to left, the spreading ischemia propagates, causing failure of this craniotomy exposure, and it lasts for some time. And again the blood flow starts restoring, and we can see here that the pial vessel are dilating again in the left and the right corner as the blood flow is getting restored. But in the center area, there is the ischemia persists. So as we have established that the spreading depolarization are result of a relative energy supply shortage at a focal area. So despite we keep a global hemodynamic parameters in check or within their acceptable changes, spreading depolarization still can occur, and therefore they need their own independent monitoring system. And the gold standard for monitoring spreading depolarization is subdural electrocorticography electrodes via craniotomy or the burr hole. So, can the usually this electrocorticography electrodes are associated with the AC amplification, because it is commonly used to monitor the spontaneous electrical activity of the brain, which happens between 0.5 to 70 hertz, and in a oscillatory pattern, that is in the alternate current pattern. But the spreading depolarization is a slow phenomenon, and it has a frequency of only about 0.01 hertz, and it is mainly a DC kind of a current which is non-oscillatory in nature, and that is why it will get filtered out by other AC amplifier which has a high pass filtering of less than 0.5. So for this, we have to use special DC coupled or ultra low frequency amplifier along with the subdural electrocorticography electrodes. So the next question is, can the scalp EEG with this DC coupled or ultra low frequency amplifier will be able to pick up this spreading depolarization? So the answer is no, is because of the presence of dura between the scalp and the cortex. This dura acts as a capacitor which stores the DC potential, whereas it allows the AC potentials to pass. That is why we are able to pick up the EEG, normal EEG activity, but we will not be able to pick up this slow DC shifts. And thus the subdural electrocorticography is considered with the DC coupled amplifiers is considered as a gold standard for monitoring spreading depolarization. So usually for ECOG, The linear strips are used because they allow continuous monitoring of about 5 centimeter extent of the cerebral cortex. Why they are preferred over the grid electrodes is because they can be easily removed bedside. So, being invasive, this also possesses a risk of infection. However, ECOG monitoring on aneurysmal subarachnoid patients has been tried for about 15 days without no infection. So the ideal placement of this linear sensor, as suggested by the COSBIT group, should be that it should target the penumbra, and it should be placed along the single gyrus. That this is a single gyrus and this linear sensor should be placed across it. It should not be placed across the major sulcus, because this will cause discontinuity in the gray matter, and the spreading depolarization may not be picked up. As well as it should not be placed too far from the penumbra, as this is our target area for the monitoring. The other monitoring are mainly focused on capturing the events that are associated with spreading depolarization. One of which is that this ionic changes causes a shift of water from extracellular to the intracellular space. This net displacement of the water can be picked up via diffusion weighted, that is DWI, or the apparent diffusion coefficient imaging. Other experimental modalities are also focused on the pathophysiology of the spreading depolarization. Cerebral microdialysis can help us identify the changes in concentration of glutamate, potassium, sodium, lactate, or glucose. PbO2 for brain tissue oxygen monitoring, or the cerebral blood flow changes can be monitored via optodes for the laser Doppler flowmetry or a diffuser tracer clearance method. Now, the problem with the non-invasive techniques is that the spreading depolarization or the events associated with it are transient. They occur for a short period of time, and they also involve a small area of the cortex. So, to pick up this such kind of a transient event at the exact moment that it is happening, with the help of non-invasive monitoring, is very difficult and impractical in clinical settings. And that is why we require an invasive type of monitoring which is continuous, and thus so far the monitoring relies only on the ECOG electrodes. Now we have seen that the pathology leads to the spreading depolarization, but the spreading depolarization also play a key role in deciding the future of these pathologies. So the focal cerebral ischemia is the most common hotspot for the SD, where the SD begins as early as 2 to 5 minutes after the onset of ischemia. SD in the ischemia does not mean that the neurons are no more salvageable, but it just puts a biological countdown, before which, if the reperfusion or the repolarization occurs, then the neurons can be salvageable. And the nature of the spreading depolarization associated with ischemia also changes based upon its distance from the core. So the first depolarizations that begin at the ischemic core are called as the anoxic SD. And because the ischemic core has a total electrical silence, these spreading depolarization are not associated with spreading depression, and hence they are called as a isoelectric spreading depolarization. The real danger begins at the rim of the ischemic core, that is between the ischemic penumbra and the core, where the actual supply demand mismatch exists, and this leads to a multifocal cluster type penumbra induced depolarization, which are associated with spreading ischemia and the spreading depolarization. Then, as the PID reach to the normal perfused area, they behave as the reversible spreading depolarization. So the hemodynamic response that follows with the ischemia is based upon the existing perfusion or the regional cerebral blood flow. So in the area which is normally perfused and it is away from the core, the spreading depolarization is associated with a monophasic spreading hyperemia. Whereas in the mild ischemic zone, the biphasic response happens where the spreading depolarization show a transient hypoperfusion phase followed by the spreading hyperemia. In more severely ischemic area, this hyperemic response totally gets abolished and the spreading depolarization is only associated with the hypoperfusion, and this hypoperfusion phase gets prolonged as we go nearer to the core, and this is what is responsible for the ischemic core expansion that we see over a period of time if the reperfusion does not take place. In case of the aneurysmal subarachnoid space, the spreading depolarization are associated with early brain injury as well as the delayed cerebral ischemia. The ionic imbalances causes the water influx into the brain and promotes the cerebral edema, which is a hallmark of the early brain injury. In delayed cerebral ischemia also, the excessive extracellular potassium from the subarachnoid clot acts as a trigger for the spreading depolarization, which in presence of an inverse hemodynamic response leads to spreading ischemia, and it is postulated as one of the mechanisms behind DCI. And this theory has also been backed by the animal data, where the topical application of the hemoglobin along with NO inhibitors converted a spreading hyperemia response to the spreading ischemia. This hemodynamic response could be different in a different patients of subarachnoid hemorrhage based upon maybe the severity of the subarachnoid hemorrhage. So in this graph, I'll explain the normal and the pathological hemodynamic response. So here we can see a blue trace of electrode 6 and a red trace of the electrode 4. This is a DC coupled trace, whereas this is a AC coupled ECOG trace. And this is the last two traces show the hemodynamic response, which was measured using laser Doppler fluorometry. So this wave of depolarization propagates from electrode 6 to electrode 4 at about 1.9 mm per minute. And this was associated with increase in the regional cerebral blood flow, as we can see in these two traces. In another patient, the wave of spreading depolarization traveled from the electrode 5 to electrode 3 at about speed of 3.1 mm per minute. And instead of spreading ischemia, it was spreading hyperemia. It was associated with an inverse hemodynamic response causing spreading ischemia. And as you can see, this creates a supply-demand mismatch, and that's why this spreading depolarization is seen prolonged. In traumatic brain injury also, SD occurs because of mechanical injury, the excitotoxicity that follows the primary insult, and the SDs are often occur in the pericontusional cortex, and they can be seen within the first 3 to 5 days of injury. And they can occur irrespective of the severity of the injury, and studies have shown that in mild head injury like concussion with associated amnesia, spreading of depolarization could be what is causing the amnesia. In post-traumatic headache as well, especially the one that mimics the migraine with aura, SDs are found to be associated. In case of the epilepsy, the source of seizure produces the excitotoxicity and the glutamate surge, which could be the common trigger between the epilepsy and the spreading depolarization. So spreading depolarization are observed while before this epilepsy starts, as well as during the epileptic episode, and also following the seizure activity. And these interictal potentials also appear as a negative shift in the DC traces, but then this negative shift is smaller than the SD and also propagates faster than the SD. The depression, post-ictal confusion that we have observed in epilepsy is also postulated because of the spreading depression that follows the spreading depolarization. So in this image, we can nicely see how the interictal potential as well as the spreading depolarization coexist. So this was a patient with right frontal contusion, and here we can see that the ECOG electrodes are placed such that the electrode 2 and 3 are on the contusion, whereas the 4, 5, 6 electrodes occupy the pericontusional area. And the red tracing represents electrode 4, green electrode 5, and the blue electrode 6. And the first three tracings are the DC, and the next three tracings are the AC amplified. And here in a different time period, we can see that a small peak of interictal potential. And in the AC amplified image, we can see that we can see the high frequency ictal activity, which is magnified here. We can see it is about 3 hertz per second. And in the another time period, these interictal potential gave rise to the spreading depolarization, which we can see preceding the interictal potential, and then as well as following it, and then it propagates to the next electrode at 1.9 mm per minute. And here you can compare that the interictal potential is almost 1 to 2 millivolts, whereas SD voltage is almost up to minus 10 millivolts. So you can also compare that the kind of metabolic burden that SD might be putting the brain as compared to epileptic focus. So, as the trigger for the spreading depolarization is the energy supply mismatch, the initial supportive treatment also is focused on stabilizing the hemodynamics in the perilesional tissue. So now we have to keep a normobaric hyperoxia, optimize the CPP, normothermia should be maintained, normoglycemia should be maintained, ICP should be less than 22 mmHg, and these all parameters can be also along with this parameter, the SD can also be monitored so that we can target at which perfusion pressure or which temperature the SD seems to get abolished. In the pharmacological modulation of spreading depolarization, experimentally various target sites have been tried based upon the pathophysiology of spreading depolarization. But so far, clinically, only NMDA receptor antagonists are used, mainly ketamine, which affects all the features associated with spreading depolarization, as well as it causes increase in the regional cerebral blood flow. And slightly higher doses of ketamine are used to get complete abolition of the spreading depolarization. Isoflurane has also been shown to be effective. Dexmedetomidine is so far used in one animal study, and it has shown to reduce the propagation as well as the frequency of the spreading depolarization. The calcium channel blockers like valproate or the topiramate are mainly used in as a anti-migraine drugs, and it reduces the amplitude, propagation, and the frequency of the spreading depolarization. Another calcium channel blocker, that is nimodipine, does not affect any electrophysiology of the spreading depolarization, but it can reduce the vasoconstrictor response that follows the irreversible spreading depolarization. This was a multivariate analysis of retrospective analysis of 115 patients who were having acute neurological injury of various pathologies. In these patients, almost 1,000 hours of ECOG recordings were monitored, where means patients received various kinds of sedatives and hypnotics. The primary aim in all those retrospective analysis was not to target spreading depolarization, but just for the sake of analysis, it was seen that the ketamine was ketamine was the only amongst all the sedative and hypnotics with the least odds ratio for the occurrence of spreading depolarization, which was also statistically significant. The limitations of the pharmacological modulations involve pharmacokinetic challenges, as we need the maximum effect to occur in the ischemic core or at the penumbra. But these areas are usually possess compromised perfusion, and therefore the drug concentration may not be achieved. Also, all these drugs are required in very high doses to establish a neuroprotective effect, and to maintain that kind of a narrow neuroprotective window, it is challenging in a clinical practice. And some drugs, like especially ketamine, develop tolerance over the period of time. Another limitation is most of the data of these trial drugs are from animal trials or from the retrospective analysis, so they may have certain flaws. Moving to the non-pharmacological modulation, the non-pharmacological strategies are mostly currently experimental, and they include trigeminal nerve stimulation, which helps by increasing the cerebral blood flow and strengthening the neurovascular response. And other modalities include vagal nerve stimulation, transcranial magnetic stimulation, transcranial direct current stimulation, or electroacupuncture. In vagal nerve stimulation, both the transcutaneous as well as the direct vagal nerve stimulation are found equally effective in reducing the spreading depolarization. And the effect is independent of the hemisphere, meaning that even if the non-injured hemisphere is stimulated, the effect is the same. Pharmacological modulation is also tried via blocking the nucleus tractus solitarius with lidocaine. The proposed mechanism behind this is a modulation of norepinephrine, serotonin, or the glutamate-induced response. Other non-pharmacological methods include hypothermia, which is seen in the experiment that to increase the seizure threshold, to increase the CSD threshold. But all the hypothermia trials, be it in the TBI, stroke, or aneurysm, have shown not to provide benefit. Lifestyle factors are currently only restricted to the migraine patients and may not be practical in the neurocritical care population, but they include regular exercise, which improves the neurovascular health, and anti-inflammatory or anti-adrenergic diets. So we have discovered quite a few things about the spreading depolarization, but still a few controversies still exist, as most of these insights are from the animal models and may not fully mimic everything in the human population. And SDs are triggered by the pathology, and they are also further are responsible for driving the secondary brain injury. So its exact role, whether it's a causative or a biomarker, is not known. In some of the areas, the spreading depolarization actually causes spreading hyperemia, which could be beneficial, especially in case of a mildly ischemic zones. So, which SDs are beneficial and which are not is not known. Some of these SDs are also reversible, while others are damaging. So the therapeutic targets cannot be decided whether we should target based whether on only the benign or the malignant. And still there is no consensus developed as to how many SDs per hour are clinically significant, and thus it can so this creates a confusion for the therapy. Having said that, I'd like to conclude my topic by saying whether a marker or mechanism, the spreading depolarizations are associated with the secondary brain injury, and hence they demand early recognition and intervention. Currently, the invasive nature of monitoring prevents the widespread application, but in future, If the bedside continuous monitoring is available, then individualized treatment plan can be made and started as soon as the diagnosis. And few emerging therapeutic targets are expected as we go on, as we know more about the pathophysiology. Thank you.
Thank you, Gayatri. Dr. Gayatri, it was a very well presented topic, which is a very complex one. Very well presented. All the aspects are covered. I think the electrophysiology, the metabolic effect of corticospreading depolarization, and the pharmacological, non-pharmacological interventions, and the clinical implications. All these things are very well presented. To summarize, will say some few words about this. As she has already pointed out, these are brain tsunamis. Okay, so whenever they occur, they create some big problems, underlying problems, and especially they will create secondary brain injuries always. Okay, so it actually overwhelms the sodium potassium ATPase system, the pump, and there is a supply demand mismatch, and that leads to the propagation of spreading depolarizations. A few questions I want to put forward to Dr. Gayatri regarding this, just to clarify these things in better understanding. You said that the spreading depression is always a consequence of cortical spreading depolarization. Is it always associated with spreading depression, or if spreading depression occurs, then it is always a consequence of spreading depolarization?
Yes, sir. So the depression of the activity happens because the membrane is already depolarized. So a depolarized membrane cannot generate an electrical activity unless it is repolarized again. So this is what causes the depression of the spontaneous electrical activity. Therefore, the spreading depression always requires a spreading depolarization to happen first.
Okay, so in continuation of this question only, why spreading hyperemia happens? Can you just explain the physiology behind it?
So the as as I have mentioned that spreading depolarization causes lot of ionic disturbances, and these ionic disturbances needs to be restored back, and that process is an energy dependent process. So increase in the energy demand has to be met with the increase in the supply as well. So, as a normal part of the physiology, the spreading depolarization are associated with the spreading hyperemia, that is, increase in the blood flow.
So basically, initial vasodilatation happens following the cortical spreading depolarization due to nitrous
Yes,
oxide release and other things. And also,
yes,
say, as she said, severe metabolic demand happens. And to mitigate that, brain has to provide, or the blood supply has to be better. This is a normal physiologic
yes,
response to that.
yes,
Whenever this response does not happen, then the inverse hemodynamic response happens. That is the spreading ischemia. So,
yes.
towards the end of the presentation, you said something that drugs, in the controversies, the drugs can also suppress the protective. This is a protective spreading hyperemia is a protective phenomenon compared to spreading ischemia. So, drugs, if we give a generalizable drug like ketamine and other things, that also can suppress the spreading hyperemia. Both things can be suppressed.
No, sir. Actually, ketamine has been shown to increase the regional cerebral blood flow. It that is this is one drug that affects the both the electrophysiology as well as the hemodynamic response associated with spreading depolarization.
Okay. So the thing is that other drugs also can suppress both. So to identify and provide a better solution, probably you have to monitor the regional blood flow, as those
Yes,
two articles have monitored the
yes,
regional blood flow along with the
yes,
spreading depolarization. So then we can probably differentiate in future which spreading depolarization is causing harm and which spreading
yes.
depolarization is most protective. Accordingly, we can take a decision. Okay, so coming to the ketamine, role of ketamine in this, what is the mechanism? Why do you think ketamine is helpful in cortical spreading depolarization?
So ketamine is a competitive NMDA receptor antagonist. So it can abolish the glutamate-related excitotoxicity, and which further triggers the spreading depolarization. So it acts via decreasing the excitotoxicity.
But at what dose is it effective?
So, from the animal studies, quite a high dose has been used. So, from like 2 milligram per kg per hour to up to almost 40 to 80 milligram per kg per hour has been used, and they have found that the complete abolition happened only at a higher doses. And in fact, even the lower doses were associated with a decrease in the cerebral blood flow as well. And only on the higher doses we achieved that more perfusion response with ketamine. But now it has been also used in clinical practice, and in clinical settings, even 2 to 4 milligram per kg per hour dose has also effectively reduced the frequency and the propagation of the spreading depolarization.
Yeah, use of ketamine, has it been translated in clinical practice as outcome improvement?
Yes, no, ketamine is the only drug that has been now is in clinical use, apart from the the valproate or topiramate, but they are still being used in the migraine population and not in the neurocritical population so far. And nimodipine has also been shown to not affect the spreading depolarization per se, but it reduces the vasoconstrictor response that may happen in pathological condition. That has been shown in one of the human trial only.
Yeah. In terms of outcome improvement with ketamine, there are several different kinds of what you say evidences are there which are supportive in nature, and those who say there is not much of improvement with ketamine at a different dose set. Okay, so that may be because of other secondary brain injuries also are associated with not only cortical spreading depolarization causes the secondary brain injury. The other things also, along with the cortical spreading depolarization, can cause other secondary brain injuries. So ketamine alone might not be effective. Along with that, we have to also think of reducing other forms of secondary brain injury to improve the outcome. Okay. So Dr. Bharat, anything in the chat box? Yeah, there is a question by Dr. Rohini. Which are the high risk cases of prone for CSDs? Yeah, can you just highlight that?
So in that depends upon the pathophysiology also. So in case of ischemia, like if the reperfusion is established, then the spreading depolarization may not be so damaging or may not even happen. But they are problematic in case if it's a malignant cerebral ischemia, or the reperfusion is not established within early period. And in case of subarachnoid hemorrhages, as well as the severity grade worsens, then those are the patients who are more prone for SDs, as well as the hemodynamic response with the SD is also reversed in those, found to be reversed in those patients.
So in neurocritical care practice, what are the typical population, like traumatic brain injury? One is
Yes.
subarachnoid hemorrhage leading to DCI, and then stroke, and then malignant stroke. In epilepsy also,
Yeah, in
So
epilepsy, and recently during intraoperative period also they have observed spreading depolarization while operating for neuro-oncological procedures. But like their like outcome relation is not yet published in the literature with respect to the neuro-operative cases.
And question about do we need to monitor CSD routine in our regular practice?
So, sir, right now the monitoring is solely relies on the invasive technique, and
Yes.
means that is the area of the controversies whether it should be regularly monitored or not monitored, because we don't know which SDs are going to be problematic and which SDs are could be just benign. So that is a area to be explored further, so that we can know in which patients we have to monitor, and also when should monitoring begin and when should it end. So because there is a one case report in which that was a traumatic brain injury patients who received electrocorticography, and they monitored for SD as well as other hemodynamics parameters, and they observed that the spreading depolarization were still happening, despite other targets like CPP, ICP was in a within normal range. And this patient was initially he had a GCS of 10T, which later on improved, and the patient was extubated and went out of the ICU as well. But the spreading depolarization still persisted in that patient, which had to be removed later on because the patient had to be shifted out. So it is still not very clear that means does spreading depolarization means that treatment is always required, or we can just target the other hemodynamics that we usually target.
And other question was, other than using subdural electrode, there is no other way of looking at CSD at bedside, right?
No, so probably we can do the cerebral blood flow measurements with optodes, but still to pinpoint that this is because of the spreading depolarization will require to simultaneously monitor electrophysiologically as well. So far it is only ECOG, and other monitoring modalities cannot be done continuously. So it is little impractical because we have to monitor at the exact time of that event. So with the discontinuous monitoring, it is not practical.
So, Gayatri, one more question on physiology. How can spreading depolarization trigger, or how is it different from normal neuronal excitability? It's also changes in action potential, no? Voltage changes happen through, yeah. How it is
No,
different from normal, yeah.
these are the voltage changes, sir, but they are constrained to the gray matter of the brain. That is, the neurons means it includes the dendrites of the neurons. It does not involve the axons of the neurons. They come under white matter of the brain. So that they differ in that. So action potential is uh, through the white matter, and not, and this spreading depolarization is only confined to the gray matter of the
Yeah,
neuron.
you meant to say, yeah, it is only confined to the gray matter. It does not propagate like neuronal action potential. And neuronal
Yes,
action potentials are very transient phenomenon, and yeah,
transient phenomenon.
they follow a particular pattern. Okay, they depolarize, then repolarize, then again ready for next batch. But here it takes a long time to go
Yes.
back to a normal state, and it's slow wave. Again, it's a very slow progress
So,
propagating wave.
yes.
Yeah.
And
So ultra
one
slow
more,
waves.
and one more thing is, like, is there any way to how do you differentiate benign and malignant CSDs? Anything described in literature?
So, sir, we have to monitor spreading depolarization along with cerebral blood flow monitoring. So, in case if the it is associated with the ischemia or inverse hemodynamic response, then they could go on to become malignant ones or the irreversible ones. So, so we have to do a simultaneous blood flow as well as the electrophysiological monitoring to know that.
Thank you, Dr. Gayatri, for the nice discussion. Dr. Rajiv, any concluding remarks?
No, she has presented nicely this concept of complex topic, and everything is, I think, most of the thing like electrophysiology, the metabolic effect, and the interventions and the clinical implications all are discussed. So yeah, it was a very nice presentation. Yeah.
Thank you, Dr. Rajiv, and thank you, Dr. Gayatri, for the lucid presentation. I think you comprehensively covered the topic. So before we wrap up today's session, I would want to invite all viewers who have not joined our Neurocritical Society of India to join us, and do visit our website www.neurocriticalcare.in to get an idea of what it is to be involved as a neurocritical care physician in India. And please do join us in our future NCSI webinars, and looking forward to having you all. Thank you everyone for joining us today.
Thank you, sir.
Thank you, everyone.